I'm here to talk to you about the researcher and the implementer and why they have a critical kinship when it comes to implementing Choosing Wisely recommendations. So I don't have any commercial support or conflicts of interest to declare. I'm supported by the University of Toronto to do the work around Choosing Wisely, which in Canada is mainly funded by Health Canada. So I have two objectives today, which is a bit of a public speaking faux pas. So one objective is I'm hoping that you'll be able to identify some opportunities to improve or increase the value of care that we deliver in primary care by virtue of the Choosing Wisely recommendations. And secondarily, I'm hoping that you'll be able to imagine how you can leverage the strengths of both researchers and implementers when it comes to operationalizing Choosing Wisely in PBRNs. So I'm just curious, how many people here consider themselves a researcher? Hands up if you're a researcher. I kind of thought it would be most people here. And who considers themselves not a researcher, but maybe an implementer, someone who gets things done? And what about both? Okay, that's great. And I didn't mean to infer that researchers don't get things done, but you'll see some of the characteristics in the literature that describes implementers and researchers. So implementers have a tendency to value just getting things done. And who here is involved in program planning or program development? Great, so lots of people. And what about policy making? So Peter Selby, you're just doing absolutely everything. You're just pride and joy of Toronto over there. So I'm going to be speaking to all of that today. So what is Choosing Wisely? Choosing Wisely initiated in the States in 2012, and it was a project of the American Board of Internal Medicine Foundation. And what they realized was that a lot of what goes on in healthcare doesn't add value to the patient's care, and up to 30% of what goes on, in fact, wasn't adding value to patient care. And so they started this campaign, which was really a call to our professionalism to come back to our duty as resource stewards, and also to our duty to carry out shared decision-making with patients, especially when we're entertaining tests, treatments, or procedures that where maybe the treatment effect isn't that great. And so the first thing they did in 2012 was they got in touch with a whole bunch of medical professional societies, and they said, give us a short list of things that go on in your discipline where the evidence is very clear that there's more harm than good, or where the evidence is very clear that it's not adding value. And so they now have 76 medical professional societies in the US, and they have 490 recommendations. The Canadian campaign started in 2014 and had a similar, kind of introduction. Medical professional societies, recommendations. So we now have 60 societies with 240 recommendations. And in the US, Choosing Wisely works closely with Consumer Reports, and they actually make both patient and provider educational material. In Canada, we've also done some work to socialize the campaign. So more is not always better in healthcare as in life. We can all think of those examples. And this is a poster, along with many others, that has actually been delivered to every family physician in the country by way of our national family medicine journal. Along with this poster or tent card, 4 questions to ask your doctor, which is really meant as a starting point for shared decision making, and especially for patients with low health literacy where they just don't even know how to start to ask us questions. Choosing Wisely is an international campaign, and this is an old slide. There are now 20 countries that have Choosing Wisely campaigns, and Canada is the lead of the international collaborative, which is supported by the Organization for Economic Cooperation and Development. And the campaign looks a little bit different in each country. So in the UK, for example, they're not so big on lists of things that we should stop doing. They're really big on shared decision making. So if you go to the Choosing Wisely UK website, you'll find a whole bunch of tools that facilitate shared decision-making, and that's their thrust. And recently, they've also started something called Referring Wisely in the UK, which is really getting to a problem that many of us know exists, which is too many upstream referrals to consultants that actually don't make a difference to the patient's care, especially when consultants refer to consultants. Personal bias. Does anyone know where the slow food movement started? Italy, yeah. So Italy has a campaign, and they're very proud of their slow food movement in Italy. It started in 1986, and it was in opposition to fast food. And the idea was that if you slowed things down and you took a more careful, thoughtful approach, you went to the farmer and you got the fruits and vegetables and you made your food at home, you're going to end up with a better end result. And so they've applied that to their Choosing Wisely campaign, and so they call it slow medicine. And so of all of the international Choosing Wisely movements, the Italian movement actually has probably the best and widest social support in their country. And interestingly, they also have a slow sex movement, but I wasn't sure, I didn't want to make a slide because I wasn't sure if the climate control could handle it in here. So that's Italy. So I'm going to show you a couple of things on the family medicine list in Canada, and the list was put forward by the College of Family Physicians of Canada. So 3 things on the list: don't do imaging for low back pain unless red flags are present. Don't use antibiotics for upper respiratory infections that are likely viral in origin, and don't order thyroid function tests for asymptomatic patients. So pretty basic, things we've learned before. But there are a number of recommendations from the other society lists that actually apply to family medicine. So here's one from the endocrinology list. Don't use free T4 or T3 to screen for hypothyroidism or to monitor or adjust L-thyroxine dose in patients with known hypothyroidism. Well, we all learned that in medical school, but for some reason, we're still doing it. Here's a recommendation that appears many times in both the American and the Canadian campaigns. Don't use benzodiazepines or other sedative hypnotics in older adults as the first choice for insomnia, agitation, or delirium. And here's one from the gastroenterology list in Canada. Don't maintain long-term PPI therapy for GI symptoms without an attempt to stop or reduce that PPI once a year in most patients. So these all seem like pretty low-hanging fruit, right? Like none of these are controversial, and the point of Choosing Wisely was not to put forward any recommendations to stop things where the evidence wasn't clear. The point of Choosing Wisely is that this is low-hanging fruit. For some reason, we're still doing this stuff, and it's a head-scratcher, right? Like, why are we still doing this? So there's a number of kind of purported reasons. Here's our clinician, and she says, well, the patient wants it. We know sometimes patients come in and they want things. They ask for tests, they ask for prescriptions, they ask for referrals, and we know especially when they ask for low-value tests, we have a hard time saying no. And a good study that looked at over 700 primary care interactions between doctors and patients in California showed us where we struggle with this. New tests are good. Technology is a wonderful thing. We have lots of innovations in medicine, and we all want to take advantage of the innovations. Better to do something than to do nothing. Sometimes it's unsatisfying when a clinical encounter ends and there's nothing to do. We all want to do something. What about the referring doctor wants it? So if I make a referral to my friendly neighborhood neurologist, I really just want his seasoned opinion as a clinician, but he might feel like, well, if I don't order an MRI, she's going to think I'm not, doing my job. So consultants sometimes fall into that. I don't want to get sued. We know this looms large, especially in the US. Sometimes there are financial incentives for overutilization, so we may be incented or reimbursed for doing certain things, tests, procedures, treatments. And then this is a big one. I've always done this. And so there's a couple studies I'll show you that demonstrate that where you train actually determines your ordering patterns going forward in your career. So this was one, this was published back in 1997. And they looked at, in Quebec, they looked at almost 5,000 physicians in Quebec, and then they compared to other provinces who looked after elderly people in the publicly funded system. And they looked at the frequency with which they were prescribing long-acting benzodiazepines. And they divided them into frequent prescribers of long-acting benzos and infrequent. And they found that among the frequent prescribers, 62% of them were from one medical school. And then this is not Quebec bashing. That medical school happened to be in Quebec. So you can see there's a real difference in prescribing patterns. Here's another one published in 2014. And this is interesting. They looked at the association between where people trained and their ability to practice conservatively. So the ABIM is deeply invested in this problem of overuse. And so now the examinees, if you're taking your qualifying exam to be an internist in the US, you will lose points if you over-investigate people. So it's not just, now, the classic internist who's got a list of differential diagnosis that's 20 points long and an investigation to go with all of them. The internists actually have to be more thoughtful, and they're losing points if they're being inappropriately aggressive. So they looked at 6,600 people writing their ABIM qualifying exam in 2007, and they looked at where they trained versus how they did on the exam. Now, they graded the intensity of the training sites. You're going to like this, Jose Pereira. They graded the intensity by looking at how many treatments or procedures patients at that training site had in the last 3 months of their life. So Dr. Pereira practices palliative care and teaches palliative care, has been my teacher. And so the high-intensity training sites were the sites where patients had many procedures in the last 3 months of life, and the low intensity were where people had fewer test treatments and procedures. So what did they find? They found that the people who were writing the exam who had trained in lower intensity training sites, they did better on what was deemed appropriately conservative management, and they did the same on appropriately aggressive management and on overall knowledge. So for those of us who teach, we should, maybe take this to heart, the way that we're kind of teaching the problem of overutilization and fumbling our way through addressing it is really important modeling for our students. Here's another survey from 2014. This was American physicians, 600 of them, and this just looks at, what they felt were the main reasons that they were likely to order things that they knew weren't necessary, and the top one was malpractice concerns. The second one was just to be safe. The third one was they wanted more information to reassure themselves. And then the fourth one was that patients were insisting on the test. So the top three reasons are really about physicians' self-assurance. Well, there's some patient factors too. So, what goes through, what's going on in the patient's psyche? Well, the internet says, we all know that in between visits with us, our patients are consulting Dr. Google. And sometimes Dr. Google takes you to reliable information and sometimes not. The MRI will show everything. It's my 4th episode of back pain. Darn it, I need an MRI. And patients don't necessarily know which tests are going to be of value and which ones aren't going to be, but they know that there are things called MRIs, and they know a few people who've had one. My buddy had a tumor. Could I have a tumor? So, there's patient anxiety. People have heard stories of people who've had bad outcomes, bad things happen, and then, but I always get codeine for my sore back. So sometimes there's just habit. Sometimes it's just the way that things have always been done. And sometimes there's physical dependence, which is obviously a driver. So why should we bother choosing wisely? So, I think no matter who is paying the bill in your health system, whether it's a provincial government in Canada or a private enterprise or an insurance company in the US, that entity has a bag of money that is finite in size, right? And we all want to take advantage, in fact, of new innovations that might be meaningful, but if we keep on doing things that aren't meaningful, We don't have any money to free up, right? But secondarily, there's this guy, Hippocrates. We all have a professional oath to do no harm to our patients and to do more good than harm. And that is a very important driver of why we should be choosing wisely. And if you consider the IHI quadruple aim, if we want to get real value out of healthcare, we need to consider, the outcomes, the harms, the benefits, the finances, and the provider and patient experience. A couple of examples of how overuse or overdiagnosis or overtreatment goes wrong. So here's a fellow, he's 64, he has debilitating knee pain for the last year. His x-ray shows severe osteoarthritis. He sees a surgeon and they decide he needs a knee replacement. So this fellow is well, he's on no medications, he has no cardiac or respiratory history, he's never smoked, but for whatever reason at this institution, they do routine pre-op chest x-rays. So he has a chest x-ray, and lo and behold, there's an unexpected finding on the chest x-ray. There is a small nodule in his right lung, and they decide to delay the surgery to investigate this. He has a CT, he has a biopsy, he has a number of respirology appointments to make all this happen. 6 months later, it's determined that the nodule is benign, and then they schedule him for surgery, which happens 3 months after that. So it's probably not hard to see that this person, sustained some harms. So first of all, surgery that was delayed by 6 months for a very painful condition. A CT chest, which would have delivered a not insignificant dose of radiation to this individual, a procedure with its inherent risks, time away from work, time away from family to attend multiple appointments, and that's to say nothing of the anxiety that this person had to live with while this nodule was being worked up. This is another case example. This occurred in a teaching hospital in Toronto, published in 2015 in JAMA Internal Medicine. So there was a 50-year-old fellow with cerebral palsy and a known seizure disorder. He was brought to the emergency department, and his chest x-ray showed some questionable aspiration findings. And so in the world of intensive care medicine, the way that aspiration or possible aspiration pneumonia is recommended to be treated, the guidelines say you wait 48 hours before you intervene with antibiotics. And the reason is because most people don't actually develop aspiration pneumonia. But the team that day kind of jumped the gun, and they thought, we're going to give him antibiotics just in case. And so they hung piperacillin, tazobactam, which is pretty high grade, antibiotics. And unfortunately, the following week, this person developed C. diff colitis, and he died from toxic megacolon. So, sometimes the consequences of too much medicine are kind of soft, more patient anxiety, and sometimes they're pretty significant. So what's the scope of the overuse problem? So the Institute of Medicine in the US has estimated and measured that 30% of healthcare spending doesn't add value to patient care, and the data from Canada is very similar. So CIHI, the Canadian Institute for Health Information, shows us whether it's lumbar spine MRIs or DEXA scans for bone density, or long-term care residents taking antipsychotics when they don't have a diagnosis of psychosis. Low-risk surgeries like cataract surgery, getting pre-op ECG and blood work, and then red cell transfusions. And I think that one's particularly hard to swallow. I'm not sure how blood donations work in the US, but in Canada, that's all voluntary blood donation. And it's a precious commodity, donated blood, and to think that we're wasting some of it is shocking. In April of this year, CIHI and Choosing Wisely Canada put out a report that looked at 8 particular Choosing Wisely recommendations and whether there might be overuse, and this really just confirmed the 30%. And some of those included things like chronic PPI use. So, what do we know from CIHI data? We know that 27% of seniors in 2015 were taking a PPI. And we spent that year $330 million from the public purse alone. So that does not include anyone with a private insurance plan. and that would not include, adults of working age, most adults of working age, unless they were on social assistance. So that's a lot of money. It was the third most common drug prescribed in the public system and the third top drug for spending. And yet international data show that 60% of patients lack a current indication for their PPI, which is not to say they didn't have an indication when they started it. It's just that the indication, has lapsed, so to speak. And, why do we care? Because PPI use chronically is associated with increased chances of community and hospital-acquired pneumonia, C. difficile, and that's where the evidence is actually most compelling. And in particular, recurrent C. difficile. If you have someone with recurrent C. difficile, get them off their PPI. Fractures, nutrient deficiencies, and chronic kidney disease. And it seems like every couple of months there's another journal article about the long-term negative consequences of PPIs. Chronic benzo use in seniors in Canada, also a problem. So 10.4% of seniors overall on a chronic benzodiazepine. And that ranges from a low in Saskatchewan there, one of the prairie provinces at 5.3%, and then a high in New Brunswick in one of the Atlantic provinces of 25.4%. That probably has most to do with the way they categorize their drugs in their public system. But there's variation, but it's high. And, high reminds us that it's important because older adults using sedative hypnotics are more likely to have car accidents, they're more likely to fall, have hip fractures, daytime fatigue, and their thinking can also be negatively affected. And so that has become actually one of the international measures for the International Choosing Wisely Collaborative. They're looking at chronic benzo use because this is a problem in many countries. And there's probably only one country that's really doing a good job at reducing this, and that's Denmark. So I was asked to lead a project to implement and measure Choosing Wisely recommendations across 6 primary care academic sites at the University of Toronto. And I thought, well, I should be able to do that. It's just QI, we're going to do some deprescribing, we're going to do some, decreasing unnecessary test ordering, this should be, I should be able to do this. And, in fact, after a while, I felt really a bit discouraged. It wasn't going as easily as I thought it should go. And I think it was for 2 main reasons. One was because there were measurement challenges. I was having trouble with the EMRs. I didn't know how to create the right searches. And the other one was, I think that QI expectations have changed, And, in the early days of QI, there were these, the Plan, Do, Study, Act. And it seems so simple, right? So under the plan, it was just, what's the who, the what, the when, the where, and, under the do, it was, just document your observations. And, under the study, it would said things like summarize your results, And, but now, it seemed back then just about any regular community physician should be able to do this, right? And thank gosh we all survived the 1990s, where the RCT was the holy grail. And in came QI, and it just saved our skins. Boy, we could all do that, right? We didn't have to think about p-values or sample sizes. So, but now the PDSA cycle looks different now, right? It's been kind of academified, if you will, and it's much more research oriented. So now under the plan, you've got things like Pareto analysis. Well, cause and effect diagrams, for heaven's sakes, And under the D, we've got things like experiment design, and under the ACT, we've got things like process mapping. And so it's really become more complex, and for heaven's sakes, I didn't feel very confident, but I realized this felt like implementation research to me. And who was I? I was just an implementer. So what is implementation research? It's a scientific study of barriers to and methods of promoting the systematic application of research findings into practice. And we can do research for implementation, or we can do research of implementation, but most importantly, the literature will tell you that implementation research depends on successful collaborations. And I really needed a collaborator. I needed a researcher. So just in case it's not clear, I'm that scared, wet little dog, right? So I needed someone who had a skill set and a set of characteristics that differed from mine. So I needed a researcher because I was the implementer. So the literature tells us that researchers have certain characteristics. So they tend to be reductionist. They like to divide things into categories. They are drawn to controlled conditions, whereas the implementer tends to be more adaptable and likes to focus on ways to do it. The implementer is also drawn to the field, which by nature has conditions that are more chaotic. Researchers often have certain favorite methodologies. So, someone does quantitative and someone only does qualitative and, stuff like that. They may be they tend to be systematic and conscientious. The implementers tend to understand their context and their stakeholders, which is also important, of course. And with implementers, getting it done sometimes trumps being systematic. And researchers, kind of operate on the principle that anything's potentially publishable. So they tend to get really organized around publication. They get their Reeb approval up front, and they're thinking down the road. And implementers often aren't that organized for publication. I can think of lots of things that when I was our family health team lead, we introduced new programs and some really fantastic things that have really stuck. And we thought of writing them up, but to be honest, I hadn't really considered that. Of writing them up. Hadn't considered that, so we didn't get research ethics approval. So the literature states that there are some cautions about researchers and implementers, and the cautions of researchers may be that sometimes they may not be that flexible in terms of methodologies. So, you might need a different methodology than your researcher actually really likes to do. They may not be that adaptable to the dynamic nature of the field. Whereas implementers can sometimes undertake monitoring or evaluation without scientific methodologies. So some people are shaking their heads, right? Like, have we seen implementation projects that kind of lacked a bit of scientific rigor sometimes? And implementers may consider the mere documentation of their findings to be research, which in fact it's not. The researchers might see the implementers as lacking in scientific solidity, and the implementers might see the researchers as putting up barriers. So I found myself a researcher, and this is her. This is Dr. Michelle Griever. She's right here. She's on the planning committee for this here conference. We work together at Utopian, which is the University of Toronto primary care PBRN. And I was a QI lead on this project, and so most of what I was doing was pretty coachy, right? I got 6 academic sites, and we were having meetings, and we were brainstorming. What are your barriers? What are your barriers? How should we deal with that? Brainstorming solutions, getting the pharmacists together from the different teams, getting the social workers together, connecting people, But we were a little low on methodology. And so, in came Michelle, and one of the first things that Michelle realized was, I was trying to get data out of 6 individual electronic medical records. She said, no. We have a PBRN-wide database from all of those and 8 other sites. So why don't we use the bigger database? And she saw an opportunity to create a project, and for which she designed a methodology, and I'll describe it to you. And she also knows how to make really good EMR searches. So she's a major technophile. And so she improved that as well. So I was very thankful to start working with her on what I initially thought was a little QI project. So I'm going to just go through a series of slides here, and I'm going to show you some examples of how implementers and researchers complement each other. So this was going back a couple years. So Michelle wanted to form this joint data warehouse, and she wanted to take data from the hospital on chronic diseases for our patients who'd been in hospital. Then she wanted to take data from the family health team database and chronic disease and put it in one place, and then she wanted to use it to improve chronic disease care. So she said, well, we've got a meeting with all 80 doctors from our family health team coming up. So she says, we'll get all 80 physicians to consent, no problem. Okay, so I was the lead of this group, and I knew these docs pretty well, the good behavior and the bad behavior, right? And I thought to myself, a couple of physicians are going to want a legal opinion. Let's get that now. So, this was, they were going to want a legal opinion about data privacy. And so what we did was we got the legal opinion up front, and then Michelle came to the meeting and she signed everyone up. They were all happy. They saw the lawyer's opinion. That was it. So that was a good one, right, Michelle? So here's another one. So researchers can sometimes, researchers can be really optimistic. We'll measure a total of 8 important outcomes by way of an elegantly constructed EMR form. And I knew the docs will not use that form. It was a veritable labyrinth, okay? So physicians will sometimes use certain tools that you put in front of them for practice, and sometimes it's just, no, they're not gonna use it. And if you know that, you can save time by getting it right from the outset. So knowing your context, knowing your stakeholders is super important. So here's another one. What's taking her so long? This is on our poverty project. So we're co-PIs with one other person on a project to screen for poverty in a targeted way using geographic information systems. So we are putting flags in our EMR for patients who live in postal code regions that are associated with the lowest income quintile in Canada. We are screening those people for poverty, and then they go on to a caseworker who helps them to optimize household income. So I had the Reeb application, and what was going on for me? I was finding the Reeb application daunting. There were parts of that application I didn't know how to answer. And being a physician, I thought to myself, well, I should know how to answer this. So I'm just going to put it away for tonight. Tomorrow, when I'm well rested, I'll look at it again. And then I would look at it again, and I still couldn't answer those questions. And, so Michelle helped me a lot on that. Thank you for that. And the project's going forward. But there was another moment of discouragement. And that was, out of the 80 docs, only 6 of them responded to the recruitment email, and 2 of them were me and Michelle, right? So I was absolutely despondent when I called Michelle. But you know what she said to me? She said, recruitment can be hard when it's an opt-in approach to the project. Let's do this together. And so, what Michelle let me know was that she'd been there before, and that she knew how to get over this hurdle. And so we did. We divided and conquered, and now we've got about 35 docs signed up, which makes it feels like it makes it a real project. And she really put the wind back in my sails on that one. So a couple others. But my practice is so busy. How will I stay on top of the project rollout? And Michelle says to me, well, we have a research assistant for that. I said, we do? So, sometimes implementers, you're just oftentimes a clinician. You don't know all the resource at department. You don't know what's behind you in the department, right? So, now we have the research assistant. We have, every 2 weeks, we have a little phone huddle about the project, and the research assistant, guess what, organizes it all and follows through with a lot of the to-do items. So that's really keeping it going. So here's another one where we're trying to measure potentially inappropriate screening as a Choosing Wisely recommendation. And, Michelle realizes, we won't be able to differentiate necessarily between screening and case finding. So that's a hard one to get from big data sets. And, in the world of an implementer, well, that will be a limitation, but let's just do it. Let's not lose momentum on this project. The clinicians are, galvanized, let's go with it. So these are kind of some of the reasons that we work well together, and some of the things that we tackle together, and we need each other, researchers and implementers. And this is one of the things we're working currently around, so at Utopian. So Choosing Wisely, monitoring quality improvement efforts to reduce thyroid screening in primary care. And we're doing this within Utopian at U of T, and we've also applied for national data from CIPSIN, the Canadian Primary Care Sentinel Surveillance Network, so that we can look across the country at this. And Dr. Alex Singer, who some of you may know from University of Manitoba, is working on that with us. And why? Why would we care about unnecessary TSH ordering? Well, first of all, there's no recommendation for population-based screening for TSHs. Secondly, it costs a lot of money. And there's high practice variation. And when you look at choosing wisely recommendations, sometimes it's hard to know what's the right rate for screening this or screening that, or, the right rate for ordering. I mean, surely some people need pre-op blood work, right? But we don't really know what the right rate is. But when you see a large amount of practice variation, that's a hint that some people are probably doing it more often than is really needed. So within our Utopian database, we have 133,000 patients, and we're looking over a 2-year period. And at baseline, 62% of the patients who do not carry a diagnosis of thyroid disease and who are not on thyroid medications had at least one TSH. And in that is included people that might be on medications that would prompt you to order TSH, like amiodarone, or people who have diseases that might put them at increased risk for thyroid dysfunction, like rheumatoid arthritis, for example. We excluded those people. And so of the 62% that had at least one TSH, 93% of those were normal, and of those normal, another 38% had another TSH in a 2-year period. So we think at baseline it looks like there's some overuse. We're working with the null hypothesis. Do you remember something about research? Okay, it's the null hypothesis. So it's always one of my favorites. So the null hypothesis that we're working under is that the 6 sites who are actually working to reduce unnecessary TSH screening will not have a rate of TSH testing that's different from the other 8 academic sites. And really what we're trying to do here is see if we can use a PBRN to provide EMR-based reporting that supports quality improvement around the overuse problem. So we're trying to operationalize choosing wisely within our PBRN here. And guess what? I didn't put this slide together. I copied and pasted it, Michelle. So it's a parallel cohort design and cross-sectional, and there's a time trend analysis. And this time series plots will be obtained using multivariate logistic regression. This is what I'm not good at, right? So this is why I needed Michelle, who put together a fantastic methodology, and this project for implementing choosing wisely across 6 sites, it's funded by a government agency, and it's, there are reporting requirements. And now that Michelle has come on board as, someone who's kind of driving research at a larger level around this, our reportables are going to be much more robust. So I'm just going to talk, this is the last part, I'll just talk a little bit about implementing choosing wisely recommendations and what it looks like in practice. So when you look at choosing wisely recommendations, there are different kinds of recommendations in terms of what you're actually implementing. And there's a URL there at the bottom. It's a link to my Google Drive. And what I did was I took the 75 recommendations from all the lists that might apply to primary care from the Canadian list, and I stratified them by implementation categories. So there's some that are about screening. There's some that are about deprescribing. Some of them are about prescribing in certain conditions. Some of them are about ordering that's linked to a certain diagnosis. Some of them are about recommending patient behavior change. And others are about providing care on a diagnostic trajectory. And I'll give you some examples of each of these. The spreadsheet, it's an Excel spreadsheet, and I have another one that's on the same Google Drive that you can access if you're a teacher, that's stratified by QI pillar. So if you're helping trainees to choose QI projects, it's an Excel spreadsheet that Alex Singer and I kind of put together that helps residents make a decision on what kind of project they want to do. So here's an example of some screening recommendations that you can implement. So don't order screening chest films or ECGs for asymptomatic or low-risk patients. So, from electronic medical records, you can probably find a preventive health visit based on, for example, billing data. And you can definitely find a result of a chest film or an ECG. Again, what's hard with the screening was that just screening or was that case finding? So that's where some of the limitations and some of the nuances come into play. Here's another one. Don't routinely do screening mammography for average risk women age 40 to 49. So, if you have really good EMR data, your family history might be coded for breast cancer or, say, ovarian cancer. And you might be able to tell if people are, maybe not average risk. The question is, for example, is genetic information coded in your EMR? So if someone carries the BRCA gene, can you find that, with a degree of ease in your EMR? So this is where some of the challenges come when you try to reduce unnecessary screening. A couple of deprescribing, so the benzo one, these are from the American campaign, don't use benzos or other sedative hypnotics in older adults. So, again, you can look in your most EMRs, it's pretty easy to find, an age cutoff, the presence or absence of a prescription. Sometimes the medication list isn't kept completely up to date, so maybe it was just an old prescription that they're not using anymore. Maybe you gave them 1 tablet of lorazepam because they were having an MRI. So, there's some limitations looking at this too. Don't use opioid treatment for migraines except as last resort. So you could probably find a diagnosis of migraine by diagnostic code, and you can find prescriptions for opioids. Prescribing linked to certain conditions, again, so don't prescribe antibiotics after IND of uncomplicated skin abscesses unless there's extensive cellulitis. Well, you could probably find a 682 diagnostic code for cellulitis, and you could probably find an accompanying prescription, but then, whether it's extensive cellulitis, the limitations there, it probably requires a bit of a chart audit. Don't prescribe antibiotics in adults with bronchitis or asthma or children with bronchiolitis. So that one might be more straightforward, actually. You could find visits that have that diagnosis and where antibiotics were or were not prescribed, and look at that. Ordering that's linked to a diagnosis. So don't obtain a urine culture unless there are clear signs and symptoms that localize to the urinary tract, or don't obtain routine blood work other than CEA during surveillance for colorectal cancer. So these are both from the American, Choosing Wisely. So, we know that people having their 5-year surveillance for colorectal cancer only need a CEA every year. And so, again, if you looked at those people and what was ordered on a yearly basis, some of them may have needed a CBC or liver enzymes, but if you see that 90 or 100% of them are getting that, there's probably some overuse. Recommending patient behavior change, it's a little bit thornier, this one. So there's a couple recommendations. Don't recommend routine or multiple daily self-glucose monitoring in adults with type 2 diabetes who are on medications that don't cause hypoglycemia. We've tried in our family health team to kind of capture this. Do we recommend self-monitoring, yes or no? Is it a discussion, yes or no? It's a bit harder to measure. What are you measuring? Whether there was a discussion or what did the patient report? Sometimes there's recall bias, so it's a bit harder. Or this one, don't prescribe acute medications or recommend over-the-counter analgesics for patients with frequent migraine, basically without using a headache diary first. So, most EMRs probably aren't, coded to capture whether someone's, using a headache diary. You could probably write that in somehow and make it searchable, but these are some of the limitations of measuring these kinds of things for Choosing Wisely. And then the last category is when we provide care on a diagnostic trajectory. So there's a couple recommendations like this. So don't delay referral for undescended testes beyond 6 months of age. And don't delay advanced care planning conversations. And these are hard to measure, right? So, when's the right time to have that conversation, in relation to any diagnosis? Well, that's highly nuanced, right? So these ones are a bit harder to measure. The test ordering and the prescribing seem to be the ones that are a little easier to measure. So, in summary, I think that the implementers and the researchers really do need each other. And I think that PBRNs are, really are kind of the place where we can do this. And in the same way that art and science balance each other, I think the implementers and the researchers also balance each other, and that intrinsically dynamic process of implementation can certainly balance the scientific rigor of research, and I think this is what we're really trying to achieve in our PBRNs. And Michelle, that's you and me. That's Michelle saying, "Show me the data." And Michelle is thinking of her microscope, and I'm thinking of my stethoscope, but together we are carrying out that message that more is not always better in healthcare as it is in life. So that's all for today.
In Quebec, we use also those tools that are translated in French, and they are used in family medicine offices, and it's very good. And I think it's important also to sensitize the medical students, even at first grade, also the trainees in family medicine, but trainees in internal medicine. As you said, we have a project in Sherbrooke actually with those trainees in family medicine and resident in emergency medicine also. So I think it's important to...
Absolutely, and I'll tell you that at Choosing Wisely Canada, which is a bilingual campaign, we receive phone calls from medical students and residents regularly. They are hungry for this information. And you know, the current batch of medical students and residents are of a generation where this message of doing less and making things more simple, that's the message of their generation. Because why? Because we have created excess, and we have done too much to the globe. We have done too much, and they see it as their mission to bring things back to a simpler level, to make less of a carbon footprint, to do less harm, to do less to patients. They love this messaging. Yeah.
Jeff Goodring from UCLA, and a site for Choosing Wisely.
Yes, a big site for implementation research, yeah.
You know, I was reflecting on your comment about why is it so hard, and one of your slides threw the answer at me, reminded me my first day of medical school when the dean said, I don't know which half of what we're going to teach you is wrong, but half is wrong. And one of the things that surprised everybody was a recent well-done clinical trial on antibiotics and simple abscesses. Mm-hmm. And the authors intended fully to prove once and for all that antibiotics did no good, was led by a magnificent ID researcher, 24 sites, and showed very significant benefit of antibiotics in the emergency department for small abscesses. So long-winded way to ask, how much of this, not for the academic physicians, but for the community-based docs who are doing most of the volume, is I've lived through this long enough to know that the pendulum swings, and what we believe is true and evident today is not.
Yeah. So, Choosing Wisely, what we do at Choosing Wisely, first of all, we do not vet the evidence. What we do is we make sure that the medical professional societies have a method that is rigorous, that looks at the evidence behind each of their recommendations. But I totally agree with you. I mean, I think that there are recommendations today and things that we are doing that in 20 years we'll be shaking our heads and thinking, why were we even doing that? And so for the medical professional societies, the way that we interact with them is we ask them to refresh their list. We ask them to relook at their recommendations on a yearly basis to make sure that none of them are, that there isn't a large amount of new evidence or a relook at the evidence that might change the recommendation. That's a very important thing to do. Yeah. And UCLA has been one of the major, so Cedars-Sinai in particular has been one of the places where they've really implemented electronic prompts and electronic ways of decreasing unnecessary utilization. So, yeah.
Thank you so much, Kim. I do have one question also. Just have you had a sense in terms of influencing on policy with regards to really heterogeneous practice across geographical spaces? So, in Calgary outspends Edmonton 2-to-1 in healthcare dollars. In Calgary, they're doing routine colonoscopies on low-risk patients for screening. Mm-hmm. In Edmonton, we're having trouble getting our patients who are actually bleeding in for colonoscopy in a timely way. So those kinds of thorny decisions around what people might want versus what we can as a system afford, to what extent is policymakers playing into this whole thing around equitable distribution of resource?
Yeah, so, Canadian doctors don't like to talk about money. And at Choosing Wisely Canada, we have not made the campaign about money, because as soon as we start talking about money, we lose the clinicians. They really do not want to talk about how a dollar value might affect the decision that you're making with one patient. And that might seem naive. But so we don't make it about money, we make it about less harm and more good. But what's happening, especially with Choosing Wisely publications, is when you see large amounts of practice variation, the payers are very interested in that data. So Health Quality Ontario, in Ontario, and the provinces, the payers are the provinces, they are very interested in our data. And we try to keep a little bit of a distance from them. We're not working directly with any payer, and we certainly don't want, for example, Alberta Health Services to be, kind of referencing Choosing Wisely in decisions to cut back on X, Y, or Z. At the same time, I think we all realize it's really important for the payer to be in line with the science. Otherwise we're paying for things that aren't making a difference. And I don't think anyone runs their pocketbook like that. So I wish there was someone here from the American Choosing Wisely campaign that could speak to the way this works in the US. But in Canada, we've kept a little bit of a distance, but our data is definitely of interest to the payers. Yeah. Having said that, we're funded primarily by Health Canada. And Health Canada doesn't fund healthcare directly in any province. Health Canada makes transfer payments to the provinces who then fund healthcare. So Health Canada is seen as having a bit of distance. So,
I want to just follow up on the comment made by a colleague from the UCLA. I think that although there may be some that will change over time, and as you said, it oscillates and the pendulum swings, but I think there are many, many things that are so wise within Choosing Wisely that are not going to change if we're selecting simply on the basis of I want to cover everything, I want to play it safe, etc. I think it's a problem. And I think there are some things that are not going to change, and I'll give an example. I'm surprised in the hospital that I work in, the number of patients who are on lipid-lowering medications, statins, at the end of life. And these are patients with chronic diseases, and they're clearly at the end of life, and they're still on statins. Mm-hmm. So I think I can't see the pendulum swinging sometime in the future, mm-hmm. that statins make a difference for someone with end-stage heart or lung disease, cancer. So I just want to compliment you on this work. It's fantastic, fantastic work. And I think the art is going to be in trying to figure out which are the ones where there may be pendulum swings in the future versus those where it's unlikely to occur.
Right.
Fantastic.
Yeah, thanks for that, Jose. We have someone from France who has worked with us at Choosing Wisely Canada. So he's a physician in Montreal, actually, and he's from France, and he's in Canada for 5 years or something. And he said when he first arrived in Canada, he couldn't believe the number of times we said, well, we need to rule out this diagnosis, rule out this, rule out that. He said in France, we just want to rule in. We just want to know what is the diagnosis. We don't have to do 5 tests to prove what isn't the diagnosis. If we know what it is, we're good. So it's a different mindset, right? So.